Now let's talk about these family of drugs that are now available to us in the treatment of ovarian cancer and where they fit in to the treatment. These family of medications called PARP inhibitors. Let's talk about their role in diagnosing and helping manage ovarian cancer.
Well, I'm very excited about PARP inhibitors. Michelle and I have already discussed them as well. So PARP means poly-ADP ribose polymerase, and PARP is an enzyme that's involved in DNA repair. So what's very interesting about this drug is it causes the DNA to break as a single-stranded break. This is really kind of maybe too much, more than you want to hear, but when that happens, these cells are more likely to die when they're exposed to chemotherapy, so you're able to kill the cancer cells.
So this is for patients who have already have a diagnosis of ovarian cancer.
Yes.
And are these drugs eligible for patients with early stage disease that may be localized, or is this really for patients who have more advanced disease?
I would reserve them for patients who have more advanced disease, and right now there's 3 drugs. They're all currently FDA approved, but they're approved for different indications. So this can get very confusing. And this is also very exciting because all these drug approvals were since 2014. So 2014, one in 2016, and one just recently in 2017. So it's really shaped what we can offer our patients, which is truly exciting. So just starting from the first one, olaparib. Olaparib is also known by its trade name Lynparza. So that's one of the drugs.
And was that one of the first drugs that was available?
That was the one that was approved in 2014. Now, this drug, Lynparza, is approved for women who have a germline mutation in BRCA and have had more than 3 prior treatment regimens.
Now, you're talking about these drugs being FDA approved since 2014, but we know that many of these drugs take a long time to get FDA approval. Were you using these drugs in clinical trials long before FDA approval?
Yes.
So you were already seeing the beneficial effects to women with ovarian cancer?
Yes, we were. And there's all these, so that was just one drug, the olaparib drug. Another drug is known as rucaparib. Its trade name is Rubraca. That was approved in December of 2016, so just a few months ago, for women who have either a germline, so the inherited mutation, or the somatic acquired mutation. And had had 2 prior chemotherapies. And then the last one, most recent one to get approved, is niraparib, also called Zejula, which was just approved a few weeks ago. And that's for women, all women, regardless of whether or not they have the BRCA mutation, who have had a recurrence and then received platinum-based chemotherapy, entered either a complete remission or had a partial response to therapy, and then they can go on this treatment to try to maintain their cancer so it doesn't get worse, it doesn't grow.
So you've described quite specific indications, which for patients who are watching this segment is quite overwhelming to understand whether they do or do not meet these eligibility criteria. Is it fair to say that if a patient takes one of these drugs, that they're put onto one of these drugs initially and fail, they have progression of disease, or if they have side effects from a particular medication, does that mean that you may be able to consider option 2 or option 3, or are the categories of eligibility very specific? So if you're eligible for A, you may not be eligible for B or C, or can you offer patients more than one of these if they fail or can't tolerate one of these medications?
So that's $1 million question. I can tell you that since we've been doing clinical trials, we've had some of our patients have gotten these PARP inhibitors on a study, and then when they progress, now they may be eligible for some of these other PARP inhibitors using their FDA indication, right? So certainly it's something I would offer. If somebody's progressed on a PARP inhibitor but did really well on that treatment and now has cancer, I wouldn't hesitate to offer them a different one.
And for patients that are eligible for these medications, in what format are they given? Is this intravenous or medication?
It's a pill medication. And so a lot of patients are very interested in a pill that they can take by mouth. I mean, Michelle, you've gone through, IV chemotherapy and are now on a pill form. there's there's a lot of differences in terms of how convenient it is to take versus having to go to the treatment room and get a 3-hour or sometimes even 5-hour plus infusion. So for some patients, they like it better. Other patients have told me they actually want an IV drug because then they don't have to remember their pill. So it's really individualistic.
But let's talk about some of the serious side effects for patients who are receiving chemotherapy intravenously. We've heard that many of the older drugs in particular have very severe side effects with nausea, particularly these platinum drugs and hair loss. Are these drugs, these newer drugs, these PARP inhibitors, are they considered chemotherapy? And just because it's a pill format, does that mean that it's going to be less toxic than receiving it IV or no?
So the most common things are really some GI toxicities, nausea and vomiting, but you control that with how you take the drug, timing it with your meals or using a medication that helps with the nausea, tiredness, and dropping the red blood cell count. So that's for one of them. For the Lynparza, that's kind of the standard side effect profile. The Rubraca also has issues with the red blood cell count, has a little, some nausea, vomiting. They all kind of have that. That can also be associated with increasing liver enzyme tests, as well as increase of a blood test called creatinine, which measures how the kidney's doing. But those, even though your liver tests or your kidney tests may go up, it really doesn't indicate that the drug is harming those organs. For the most part, if you just watch it, it'll stabilize out pretty quickly. You can either maintain the dose or maybe drop the dose.
So for these medications, do you often find that patients, you would like to put them on these medications because they should have a response, but are there certain groups of patients where they have a high risk of reacting badly, and you might say, well, we're not even going to go there, that they have a contraindication, or are most patients eligible?
Yeah, so let me just talk about the last one because I didn't get to niraparib, which is also called Zejula. That profile is the same as the other two, but it does tend to have more decrease in platelets. So you have to really watch the platelet count closely with that drug.
So for patients, that may mean that they have issues with blood clotting, inability to clot the blood.
Right, they might have increases of bleeding. But I've worked with that drug quite a bit too, and you just have to be careful with the dose. Just drop the dose quickly. Day 15, if the platelets start to go down, decrease your dose. But really watch the blood cell count closely. So going back to your question, who would maybe not be a good candidate for these drugs? So these drugs are all given orally. So if somebody has developed issues with their bowels not working well because of the cancer, they may not be able to, take these drugs, keep them down, and digest them. And so that's a group of patients that they may not work as well. So my preference in thinking about how I'm going to use these agents, I like to use them sooner rather than wait till, a later indication.
So from what you're saying, if these drugs are managed by experts in the field who are very familiar with how to use them and what potential side effects may be associated with these medications, if they're used appropriately at the right dose for the right patient at the right time with the appropriate monitoring, it sounds, correct me if I'm wrong, but it sounds like they are actually quite well tolerated for patients.
Right, I think so. And then the important thing to note with Lynparza, for instance, the FDA-approved form right now is a capsule. There's several studies ongoing around the country and around the world actually with this drug in their new formulation, which is a tablet, and that new formulation seems to be better approved. So I'm hopeful that will eventually be the FDA-approved formulation.
Now we hear